Good afternoon, and thank you for joining us for today's webinar. This is Tiffany Hatcher of University Hospitals. A couple housekeeping notes before we begin. In this platform, all attendees will be muted. While you won't be able to ask questions through audio, please note the Q&A function on your screen. If you have a question that is not addressed in the presentations, please submit through the Q&A feature, and our presenters will try to address as many as possible at the end. Also, today's webinar is being recorded and will be posted on our website. As a registrant of today's session, you will receive an email with the link once it's live. It is now my pleasure to introduce our moderator and first speaker for today. Dr. Sanjay Rajagopalan is Chief of the Division of Cardiovascular Medicine for the University Hospital System. He is also Director of the Cardiovascular Research Institute and the Herman K. Hellerstein Professor of Cardiovascular Research at Case Western Reserve University School of Medicine. I'll now turn it over to Dr. Rajagopalan to introduce our other panelists and begin the presentation.
Thank you, Tiffany. It's really a pleasure to be here with you all today and a very important topic on safe cardiovascular testing during COVID-19. This is a topic that unfortunately has caused a lot of concern amongst patients because the COVID-19 pandemic has made people hesitant to go anywhere in public. And that has included seeking healthcare for conditions that they may need attention for. And unfortunately, what has happened is patients have postponed getting care for essential conditions. We all know the delay of care could result in poorer health outcomes and even life-threatening situations, as no one should delay care for medical conditions because you're too afraid of COVID-19. And what we're going to do today, hopefully, is to provide information that can reassure patients, family members, and others that might be in such a situation. Now, a good example is conditions like stroke or heart attacks, which we know has a treatment that can prevent or can be life-saving. And to receive this treatment, people must come into the hospital within the first few hours of the onset of symptoms. Unfortunately, what we have seen is a lot of delays with patients postponing their illness and coming in, unfortunately, when it's a little too late. Now, the other scenario that we're going to discuss in some detail today are stable conditions, patients requiring preventive treatments, testing for cardiovascular conditions, and the anxiety related to contracting COVID-19 has been a huge mental deterrent. So patients just don't want to come in to the hospital to get their necessary tests and evaluations. Now, this we all know is extremely important in keeping patients healthy. And we are here to provide information that can reassure all of you that the University Hospital environment is a very safe environment to undergo testing. So the webinar today will focus on this issue in some detail. We have with me 4 world-class physicians who are exceptional in what they do, and you'll hear from them about these very issues. We'll find out what UH is doing to flatten the curve and how safe you are in the UH environment where all of the routine testing goes on, many of which directed at preventive approaches so that we can keep you out of the hospital. So as Tiffany mentioned, I think the way these webinars go in general is that you jot down your questions, and hopefully you have plenty of questions, and we will address all of them at the end of the chat. So please take down questions and don't hesitate to ask these questions at the end. Now, the number that you see at the end, at the top of the screen here, the bottom of the screen rather, 216-465-7893, is just so that you might have that, jot that down as well in case you need appointments or any of your family members need to talk to a physician to seek guidance on what to do. So without much ado, I'm going to get started. So with me today are Dr. Chip Gilkison, who is the Director of Cardiovascular Imaging in Radiology, is a world-class expert in cardiovascular imaging, and was also a professor at the Case Western Reserve School of Medicine. Dr. Brian Hoyt, who's the Director for Echocardiography for University Hospitals, again, a professor at the Case Western Reserve School of Medicine. Dr. Raju Modi, who many of you might know, Medical Director of the Harrington Heart and Vascular Institute at University Hospitals Parma, professor of the Case Western Reserve School of Medicine, and Dr. Imran Rashid, who directs our cardiovascular MR efforts and is also with the Case Western Reserve School of Medicine. So before we begin, I think the way we're going to do this is I'm going to start with some introductory remarks about general safe practices at UH for cardiovascular testing. And then I'm going to turn this over to each one of my distinguished panelists who's going to talk about domain-specific considerations as it pertains to cardiovascular testing. And then we'll round this up at the end with questions. So I'll provide this overview, and then we'll go on to each of these individual modalities. And this is also meant to be informational to all of you so that you can learn a little bit about each of the modalities. And again, what are the safe practices that are being put into place. So the first thing I wanted to tell you is a place where you can get a lot of this information, uhhospitals.org, healthcare update. And one of the things that's happened very, very well at UH is the putting together of what we consider are 3 critically important steps to keep our patients and physicians safe. And those 3 things you all know already. And if you don't, I would strongly encourage you to practice these measures. Those include things like social distancing, wearing a mask, hand hygiene. And from an institutional perspective, what's been very important is institutional-wide screenings where anybody coming into the hospital environment is screened for flu symptoms. And if they display any concern for flu-like symptoms, they're obviously kept out of the hospital. In addition to that, every facility, every place where patients and physicians congregate or where the testing is being done goes through some very elaborate enhanced cleaning schedules. There is an unbelievable amount of attention placed to schedule management, where this is to allow things like congregation from not happening. So when you come in for your test, you're actually placed in isolation. And this is managed to a very efficient schedule so that we keep patients from coming in contact with each other. So you can be rest assured that when you come into the university hospital environment, it's in a very safe environment where there is an abundant amount of precaution and steps being taken to keep you safe. Finally, as I mentioned earlier, there are visitor restrictions as well, where there isn't large numbers of individuals are not being allowed into the hospital environment unless it's absolutely necessary to do so. It's typically one individual coming in with the patient. I wanted to take a minute or so to talk about the importance of masks, because we still find, I went out to the grocery store yesterday and still found individuals, walking around without masks. And this is something that we all have to pay attention to. It's a social responsibility. And this cartoon, taken from a recent paper that we published, talks about exactly why masks are effective, right? We know COVID-19 is spread through droplets and aerosols. Aerosols are very small particles, typically less than 10 microns in diameter, whereas large droplets, which can have a very large concentration of viral particles, are things that one generates, especially when you're coughing. And wearing a mask is very effective in preventing large spray droplets. And this is a very important mode of transmission of the virus. And it's very important for preventing community spread. It's also important, obviously, in preventing you from inhaling large spray droplets. Now, one of the things that's often brought up is wearing things like a surgical mask or even a cloth mask might not be very effective in reducing aerosols, typically particles that are less than 10 microns in diameter. And while this is true, it's not entirely true, because even wearing a cloth mask or even wearing a surgical mask can be quite effective in at least blocking 40 to 50% of these so-called small aerosol particles. And if worn correctly, a simple face mask can be effective in reducing exposure to even aerosols. So this is something that I'd like for people to consider. And wearing a mask is very important, something that we practice routinely. In fact, it's a rule in the UH environment to wear a mask. And if I see somebody not wearing a mask, I often take them aside and make sure that they wear a mask. So you can be assured when you come into the UH environment that everybody's going to be masked, and you can be rest assured that this is going to be safe. Now, the only other slide that I have is really to show this at the end, which is all the practices that are put into place at UH as it pertains to cardiovascular testing are in adherence with national guidelines. The slide depicts all of the major organizations, each of which has provided their own guidance as to what type of procedures, what type of practices are safe, what circumstances should dictate certain types of things taking place to prevent exposure to COVID-19. And again, all of the practices put into place at UH are best practices that are consistent with national guidelines. Now, another thing that UH has done is really provide very explicit information, not only for people coming into UH, but also for employers. This is what we refer to as a healthy restart for employers, designed to keep employees and customers safe. And if you're interested, you can go to this website, uhhospitals.org, healthcare update, and download the playbook, which sort of goes through very elaborate information about what type of practices are considered important in keeping your employees and customers safe. So I'll stop there and turn this over to my esteemed colleague, Dr. Raju Modi, who's going to talk about stress testing during COVID-19. Raju?
Hi, Sanjay. Can you give me control of the slides?
Yes, you can share your screen now. All you have to do is hit the green button at the bottom. Yeah.
There we go. Can you see that okay?
Yes, we can.
All right, great. Thank you, Dr. Raju Kapalan, for inviting me to participate in this panel. I think it's an important topic of conversation to discuss the various types of cardiovascular testing that we have available to us and to reinforce that we are able to do this safely in this environment of COVID-19 and that the importance of this testing cannot be understated. I think we went through a period where we were not testing a lot of people because of an abundance of fear, both on our part and the patient's part. But we are now ramping back up, and the important information that we get from this testing cannot be underestimated, especially when it comes to cardiovascular disease. Like many fields of medicine, with cardiovascular disease, we supplement our clinical skills with imaging and testing to help arrive at an appropriate diagnosis. The consequences and the implications of cardiac disease is obviously life-threatening, and so the importance of testing is going to be reinforced today. I think there's going to be a lot of commonality in the discussions as far as what we're doing to ensure safety. I'm specifically going to speak about stress testing, and we're going to go through the different types of stress tests that are available and what we may and may not be utilizing right now in this era of COVID-19. The first slide is just representing a regular stress EKG, which is a fantastic test to identify cardiovascular disease. On this, the patient is exercising on a treadmill for a period of time with varying protocols where the treadmill speeds up and escalates in inclination. We have someone who's monitoring the blood pressure. We have continuous EKG monitoring of that individual, and we allow them to exercise to their symptomatic maximum. This test gives me a huge amount of information regarding their ability to exercise, which directly correlates with their prognosis, but it also gives me enormous amounts of information regarding exercise-associated symptoms and EKG changes. The obvious concern with exercise stress testing right now in the era of COVID-19 is the aerosolization that occurs when somebody's on the treadmill and obviously breathing heavy. To help mitigate that risk and to keep our patients safe and to keep our frontline medical staff safe, we have implemented policies where everybody will wear a mask even when they're on the treadmill. Obviously, that decreases the ability to exercise as much as we would want, but it is an effective way to reduce the aerosolization. Our nurses and our technicians are all wearing N95 masks when they do an exercise stress test and also are wearing face shields to maintain protection. Often a regular stress EKG may not be enough to get the information that's needed, and so therefore we will add an imaging test in addition to the stress test. The first one I'd like to speak about, and I think Dr. Hoyt might get into more, is a stress echo. This is where we have an ultrasound image of the heart that's performed at baseline while a patient's in a supine state. That patient then gets on a treadmill and conducts an exercise stress test similar to what we were discussing before with the EKG monitoring and the blood pressure monitoring. And then after they're done, they lay back on the table very quickly and have additional ultrasonographic images obtained by the sonographer. This is an excellent test because it gives us visualization of what the heart looks like at rest and with activity. The problem with this test in the era of COVID-19, this test exposes our frontline medical staff to the highest risk of aerosolization. You can imagine after you get done exercising and lay down on the table, you're within a foot or two of the sonographer's face, and the patients are generally breathing very heavily. For that reason, we have been trying to minimize use of stress echocardiograms as much as possible. We have an alternative test, which is a chemical or pharmacologic stress echo, where we again obtain ultrasonographic images of the heart. This time we infuse an agent called dobutamine, which increases the heart rate. This simulates stress to some degree and allows us to image the patient continuously as the medication is infusing. We can see the heart, we can see if there's any development of abnormalities in the heart structure and function with this. This test also puts the sonographer in close proximity to the patient, but because the patient didn't exercise, they're not breathing nearly as hard. For sake of time, I'll just kind of get to the next test. This is a nuclear stress test, which I'm sure many people in the audience are familiar with. This is a common way of imaging the heart, and it involves the use of a large device called a gamma camera that you're seeing on that image. What we do with a nuclear stress test is we inject a very low radiation, a low dose of a nuclear tracer. It's a very low radiation profile. That circulates throughout the body. We put the patient on a gamma camera and we take focus pictures of the heart. Wherever the blood is flowing is where the radioactivity will go. We then have the patient exercise with our usual protocols, and at the peak of exercise, when they can no longer go any further, we inject a second dose of a radioactive tracer. Then we image the patient again. What this allows us to do is to compare where the blood flow was at rest as opposed to where the blood flow is with exercise. And it can help highlight differences in blood flow, which may indicate a significant blockage. This again involves an exercise test. So we do ask the patients to wear a mask. We ask our staff to wear N95s. Between every one of these types of tests, just to back up a little bit, between every patient, everything is cleaned down, everything is scrubbed down, the blood pressure cuffs are cleaned, everybody adheres to the strictest of hygiene. An alternative to the exercise nuclear stress test is a pharmacologic or medical stress test. This involves the similar protocol where we inject a radioactive isotope. We put the patient under a gamma camera, take pictures, but this time instead of exercising, we inject a medication called regadenoson. What regadenoson does is it causes dilatation of the coronary arteries. After that's injected, we image the patient again, and we can see discrepancies in blood flow to the various portions of the heart. And just as a quick example, you can see on the top line of images where my arrow is pointing, the area looks like it's less intensely orange than the area right below it. The area below it is the resting images. That implies that that portion of the heart is not getting the dose of radioactivity that the previous images showed. When that patient goes to the cath lab, we're able to find a very severe blockage that was able to be treated effectively. So in conclusion, there are multiple tests, multiple stress tests that are available to us. We try to choose the test that least impacts the patient, arrives at the proper diagnosis, and keeps everybody safe. With that, I'll turn it over to Dr. Hoyt.
Thank you, Raju. At the bottom, Brian? Yeah, there you go. I think you're muted, Brian. While we're just getting
now, can you hear me? Can you see me?
Yes, we can.
Okay, excellent.
Thank you.
Thank you very much, Raju. And Sanjay, thanks for the invitation to come and join the panel this afternoon. And good afternoon to everybody out there. So, COVID-19. COVID-19 is not just a respiratory disease, but has major effects on cardiovascular system. Given the risk of cardiovascular complications in the setting of COVID-19, including pre-existing cardiac disease, acute cardiac injury, and drug-related myocardial damage, echocardiographic services are required in the care of many patients with known or suspected COVID-19. And consequently, echo providers, sonographers, physicians, and nurses will be exposed to the SARS-CoV-2 virus. Now, who should get an echo? Well, before the COVID era, if you wanted an echo, you could get an echo. But these days, it's not quite so easy. Now, echoes can be of three different varieties. One is a transthoracic echo. One is, as you saw, the stress echo. And the third is a transesophageal echocardiogram, in which a tube is placed down the esophagus, a transducer or a microphone is placed at the tip of the transducer. So why get an echo? Well, it is extremely available. It is entirely non-invasive. It's portable. It's extremely versatile and safe. And it has very good resolution. So this is a test that I suspect that a number of you out there have experienced. Now, in general, echoes should be performed if they're expected to provide clinical benefit. Why else would one do that? And repeat examinations, which are not infrequent, should really only be done if there's been a change in the clinical status. Well, with COVID-19, it became important to preserve resources, to limit exposure, and to plan for a potential surge in cases, so that we became very involved in determining whether or not a study, an echocardiogram, could be postponed. And we asked ourselves some simple questions. Is the patient at risk for complications or death if the echo is not performed? Will imaging change the patient's overall course? And finally, do I need to do it now? Well, transesophageal echocardiography is particularly important in terms of postponing or canceling the procedure. And one does that, and we discuss this with the referring physicians, if we think that the result is unlikely to change clinical care, or if an alternative imaging modality can provide the necessary information. For example, instead of doing a stress echocardiogram, convert that into a dobutamine stress test. And we were very successful in reducing the number of transthoracic studies. Here you can see the transthoracic volume from March 9th to May 24th. The baseline volume you can see up here. This is the yellow is all inpatients and outpatients. The blue are the inpatients. And note here that the number of outpatient studies in red took a rapid dive. In fact, we went a week doing only 17 outpatients, and you can see that we would be averaging about 115 to 130 or so a week. So this was very effective, and when we reopened, you can see that the volume increased as you would expect. Now, how is the echo performed? This ends up being a very important consideration. The protocols have to be changed. Instead of doing a comprehensive echocardiogram, the idea in terms of limiting exposure was to do very focused studies and to limit exposure by not using students, novices. In fact, we would forego the electrocardiographic leads that we use on the transthoracic study. The protection, well, there's three different levels of protection. The standard care is hand washing and the use of gloves. Droplets, as Dr. Rajagopalan discussed, droplet precautions then include gown, gloves, head covers, face masks, either a surgical or an N95 mask, as well as an eye shield. And finally, the greatest amount of protection is with the airborne precautions, the N95 mask, and the use of shoe covers. Also important to take care of the machine, making sure that it's sanitized. Probes, transesophageal probes and transthoracic probes can be ensheathed. The console of the ultrasonograph can be covered. We use dedicated machines, some handheld machines, and then there are special precautions for transesophageal echo. All of our training has essentially moved online, and we also give consideration to certain staff in terms of their potential exposure. Those individuals over 60, I hate to call that elderly, but some people do. Those with chronic comorbid conditions, those with impaired immune function, and in the pregnant individual. And finally, the reading rooms also are clean. It's cleaned frequently. This is an area where people tend to congregate, and things have moved so they're much more online. And we get to the reintroduction to the outpatient services. This has to be safe and efficient. We watch very carefully the case trends of COVID-19, and we reschedule by priority and implement protective and sanitation protocols. Patients who are getting a transesophageal echo, there is one additional step. They are tested for the virus within 72 hours of the procedure. Scheduling of deferred cases is based on where they are within the queue, what their symptom status is, the indication for the exam, and these are done with consultation with the referring physician. All of the impacts on laboratory efficiency, that is the social distancing protocols, the lengthening the time between the procedures because of entrance procedures, doing kind of a first line temperature screen and a symptom screen. All of these things have changed the way, or at least the extent of the efficiency of the echo lab. And finally, there is a phasic reopening plan. So level 2 is the initial phase with a reintroduction of select services. Level 1, there is a reintroduction of most of the services with appropriate cautions. And finally, level 0 is the provision for all routine services with ongoing viral testing and surveillance with monitoring of protective equipment supplies. And I will now turn this over to, can't hear you, Sanjay.
Thank you, Dr. Hoyt. And Dr. Rashid will now go through the safety measures in place for cardiovascular MRI testing. Dr. Rashid.
Thank you, Sanjay. Thank you for inviting me to be on this panel. And thank you to Roger and Brian for some great presentations. So I'm going to be talking about, cardiac MRI today. Relatively speaking, it's probably one of the newer types of heart imaging that is available, and we're performing it at 3 centers at UH. So there's many reasons why your doctor might refer you for a cardiac MRI, but one of the primary purposes is to assess the structure and function of the heart. And MRI does this by generating and manipulating a magnetic field to produce really kind of high quality images of the heart, such as you can see on the right of screen here. So we can actually get an image of a beating heart in the chest. In this case, this is my heart. And that allows us to assess basically the heart's structure and function very accurately. Another aspect of MRI that is very useful is that it allows us to assess tissue qualities in the heart muscle. And this is something that's fairly unique to MRI. And we anticipate that in the months, basically as we go, into the months ahead after this COVID pandemic unwinds, the patients who've had damage to their heart muscle due to infections will be able to be identified using MRI. So we think it's going to be a very important modality going forward to actually assess and map out what have been the cardiac repercussions of having COVID-19 in our population. In addition to assessing cardiac structure and function, we can also assess perfusion. So that's assessing the blood supply to the heart muscle. And this is similar to the nuclear stress testing that Dr. Modi was talking about previously. But we can do it by assessing the first pass of the contrast agents. We basically administer a contrast agent and watch it kind of wash into the heart muscle tissue. And ultimately what we're trying to assess is if there are any blockages in the major arteries of the heart that could be causing a symptom such as chest pain or weakness in the heart muscle. And finally, we do have access to some specialized tests such as exercise stress MRI. These are not kind of universally available. They're usually limited to quite advanced centers, but we do have access to that here at university hospitals. So we are committed to basically providing a safe environment and instituting policies that allow for this for our patients and our staff. And this is really important because it's been alluded to earlier that cardiac testing is essential. These are tests that can identify patients who are at risk of having adverse events, basically, and adverse events when it comes to cardiac disease are things that ultimately can be lethal if they're not treated in a timely manner. But fortunately, there are many kind of international authorities and societies, and in the case of cardiac MRI, we have the Society for Cardiovascular Magnetic Resonance, who have clearly kind of outlined ways in which that we can administer these tests in a safe manner. A lot of the things are kind of common sense principles, but implementing them really has a big kind of impact on basically reducing patients and staff risk. So it starts off with basically the planning phase. So as a patient, when you call in to have your test, you will basically be asked screening questions about whether you've had symptoms or basically been exposed to patients with COVID-19 or have had recent travel. So from the very beginning, when you basically call in to schedule your test, the risk stratification begins. Thereafter, when we receive a referral, we're looking at the clinical information to see whether it's an appropriate test, and we're thinking about whether an alternate test might be better suited towards getting the same information but in a safe fashion. And on our side, if we come across that situation, then we're directly kind of contacting referrers to work out what's the best strategy for our patients. So we're really kind of tailoring it, basically to get the appropriate test for the appropriate patient. Within the hospital, we've talked about physical distancing, and it's very apparent, we're within basically the common areas and in the waiting rooms themselves, you can see that these things are being enforced. And obviously we've talked kind of broadly about personal protective equipment, universal masking, kind of constant hand hygiene to kind of minimize the spread or kind of minimize the risk to patients and staff. Within the scan itself, so unlike echocardiography, MRI, the technician, when they're actually performing the scan, is actually in a separate room, in the MRI control room. So there is a natural physical distancing. But the other things we're doing, in MRI, we have a whole range of kind of, imaging tools that we can use to try and characterize disease. But we're kind of tailoring the imaging that we perform to the clinical question. And we're doing that to kind of minimize the scan time, to try and kind of, minimize the exposures to the patient. So we're trying to rationalize and become more efficient in that regard. Finally, we've mentioned cleaning, so that after every patient has gone through a consultation room or through the scanner, this equipment is cleaned, and the waiting rooms are routinely cleaned multiple times a day. So these are things that are in place, but if we go into the specifics, so as a patient at university hospitals, when you call to schedule your cardiac MRI, you will be asked about basically fever, cough, exposure to contacts, and recent travel. So it starts at that point in time. Thereafter, as I mentioned, as soon as we receive your referral, we're basically gauging from clinical history and basically what other modalities are available as to whether that is the best test for you. If you haven't come to the hospital lately, when you arrive, every single entry point to the hospital has staff who will ask you the screening questions again, just to make sure, in case something has evolved since the time that you scheduled the test, and who will take your temperature. And of course, we have a universal masking policy, which really, it does, basically mitigate any risk of when you're in the hospital. When you walk into the hospital, there's a lot less people. For those of you who've been to UH before, I think 6 months ago, it was a bustling area in the common areas in UH where people are kind of socializing. When you come in now, it's very much a different story. So it just enables physical distancing by having only patients who are coming in for a procedure or a consultation and with one visitor allowed per patient. So that's very apparent when you come in, and that's obviously a safety measure. In the scan, we talked about there is a natural physical distancing with an MRI because it's one technician. There is obviously, there's a preparation phase, but there's not that continual exposure. So throughout the course of a half an hour to 45-minute scan, the technician is actually in a separate room. And as I mentioned, the MRI and consultation rooms are cleaned after each visit. For the stress MRI, this is kind of, I guess, a specialized test that we do at UH at main campus. And as you can see, the images on the right, we can either have a treadmill set up next to the MRI scan or even a bicycle attached to the end of the MRI scanner. So the safety concerns for this are similar to what was previously described for stress echocardiography, mainly because when a patient is exercising, there is increased risk associated with the aerosolization of basically the exhaled air, and the fact that we need to have staff at the patient's side to basically continually monitor their blood pressure, etc. So there's continual monitoring. And for that reason, we have similar kind of, I guess, protective measures for our staff in terms of using N95 or N99 masks, gown, gloves, face shields, etc. And we prefer for a patient to have a mask on, if it, loose fitting, if it can be, just for comfort's sake, but to minimize kind of propulsion of droplets during the scan. But that kind of, I mean, that's just an outline of, I guess, the safety measures that we've put in place within, I guess, cardiac MRI to try and allow for these important tests to continue on as we move ahead. And with that, I will pass it on to Dr. Wilkinson.
Thanks, Imran. And, sorry, can you hear me? Sorry, I can't hear you,
I can hear you.
Okay, yeah, okay.
I'm just going to turn your slide, put your slides on, and here we go.
Great.
You should be able to see my slides now, so I'm on to the first slide.
Thank you.
Oops. Sorry about that.
No problem.
It should be. Here we go.
Well, thanks, everybody. And I'll ask you just to advance the slides, Sanjay. Thank you, Sanjay, for inviting me for this obviously very important topic for all our patients. I'm going to talk a little bit about cardiovascular computed tomography, or CT, and in the COVID era. Cardiovascular CT scan at university hospitals is an important part of the imaging tools that we use to evaluate patients. And I'm going to just go through the basic reasons and indications that your doctor may ask you, and the importance of CT and the role CT can play in your future management and assessment for cardiac disease. The three basic modalities that we're doing is coronary artery calcium CT scoring for cardiac risk assessment. There is coronary CT angiography for evaluation of patients with chest pain. CT angiography becomes a very important tool for the preoperative and pre-procedural planning for a variety of different indications. One of them is cardiac surgery, and CT is an important procedure often for your cardiac surgeons. If they're planning to do cardiac surgery, CT angiogram can give the surgeon a lot of tools and imaging indications to help plan your surgery. Type of indications, particularly, is if your doctor has thought that perhaps you may have an indication to do a minimally invasive aortic valve replacement or minimally invasive mitral valve replacement, CT and imaging with CT before that procedure is very helpful and important to plan the procedure safely and appropriately for you. So CT does have an important role for your care moving forward with your cardiologist and your PCP. So with that, the next example, I just want to go through very sort of quickly the basic modalities, maybe yes. Now, coronary artery calcium CT scoring, we do many studies. And here I'll show you, this is an image, this is the x-ray here of your heart, and that white is some calcium. And many studies have shown, and your doctors and cardiologists certainly know, that the amount of that white or the amount of calcium really can be an important piece of information for thinking about next steps for you in terms of management, therapies for statin therapies or exercise therapies. So this information and we will give you, after this calcium score, a calcium score can really help determine next steps for you for your care and your risk assessment for cardiac disease and stroke. And it's been very helpful. We've been doing this safely, and these are throughout all the sites at university hospitals and the systems, both from Elyria to Conneaut, at over 50,000 patients at this point. So we've been doing this before, obviously, as Dr. Modi and Dr. Hoyt and Rashid have talked about, the numbers have decreased with the onset of COVID-19, but we have increased our numbers again, and it is an important risk assessment tool for your doctor. So CT angiography, and particularly with the ability to actually measure non-invasively, measure blood flow and significance of any coronary artery stenosis with, maybe you've heard about this in some of university hospitals, releases with heart flow. Now, here's a CT scan on the left, CT angiogram of your coronary arteries we do on a CT, but also with using some very computationally intensive methods and a artificial intelligence tool to really measure if there is a blockage or narrowing, the physiologic importance of that narrowing here non-invasively with a coronary CTA with the additional evaluation with heart flow is a non-invasive way to assess a narrowing or blockage and if that's going to be physiologically significant. Coronary CTAs are also done in many places, obviously through the health system. As we talked about as well, CT angiography can be a very important adjunctive bit of information for your surgeon or your cardiologist to help plan the next step in terms of open surgery or minimally invasive surgery. The CT and the information that CT provides can be very helpful to the physician, for your physician, to plan your next steps in terms of therapies and any kind of procedures. So I think, again, with that, many of the principles that our previous speakers have been talking about, principles are always true. Whether this is going to be at a HUJA or the main campus, and this is a CT scanner here, procedures are true. There's universal masking. There will be physical distancing at any waiting room or common area. As Dr. Rajit talked about with the MRI scanners, all these CT scanners and any surfaces are cleaned before and after completely with sanitation procedures for any procedures for you to have a CT scan. So I think we are all practicing a very consistent and very safe procedure for your imaging procedure at university hospitals. So with that, I'll take it back to Sanjay.
Thank you very much, Dr. Gilkison. And again, thank you to all our excellent panelists for the overview of cardiovascular testing, and also, very importantly, outlining the incredible amount of attention that's been put into formulating guidelines as well as very specific practices that are in place now to keep the environment safe. So I'm going to welcome the audience to forward questions to us. I think we have another 15 minutes or so where we'll be happy to address any questions that you might have. But let me sort of open the conversation a little bit by asking our panelists some very specific questions about testing. So Dr. Hoyt, I think, as we all know, echocardiography is a modality that most patients are very familiar with. It's one of the most widely used cardiovascular tests. In fact, I would go as much as saying that the echo is fundamentally important for us to understand the heart, so much so that it's an essential modality that everybody undergoing a cardiovascular evaluation is almost mandatory. And I would also submit that many patients that are being seen virtually now are often seen without the traditional guidance of physical examination. So we have to examine patients over a computer screen, talk to them. And I think it's very important that we have some additional information about the patient. And this often comes across or comes through with an echocardiogram. So what are we telling patients at UH to make them comfortable that when indicated, that they ought to come in and not delay getting these procedures done? So what would you tell patients in order to allay their anxieties?
Well, thanks for that question, Sanjay. First, I think that you have to stress the importance of the echocardiogram. The echo is being ordered because it is thought that the information from it is going to have a significant impact on one's care. The Echo Lab goes through a great deal as we have reviewed this past hour, making sure that everything is clean and wiped down, that everyone wears masks, that social distancing is maintained. Rooms are fairly well ventilated. And so, I mean, there's really a negligible risk with the way that we have re-entered the post-COVID, if you will, era. So I think that the patient coming in for a transthoracic echo, this is really droplet kind of precautions, and patients and the sonographers wear masks. Dobutamine echo, and as I mentioned, stress echo, we try to convert to a dobutamine echo whenever we can. Exercise aerosolizes particles and increase exposure to virus. Dobutamine, you start looking at simply needing a droplet precautions as a mask, whereas N95, surgical mask, N95s are used for the stress echoes. For transesophageal echocardiogram, as I mentioned, you have viral testing within 72 hours. Transesophageal echo, where you put a probe down someone's esophagus, is a stimulus for coughing and gagging, and both of those things aerosolize the virus. And so everyone wears N95 masks and have full aerosol precautions. So I think that it's like the risk benefit that we deal with all of the time. The amount of information to get is enormous, and the risks are really very small.
Thank you. Thank you for that perspective. It's really important. I think everything has, a risk and a benefit, and one needs to, even crossing the road, for instance, has a risk and benefit, and one needs to make an informed decision based on information that you're going to get from it. And it certainly pertains to a number of cardiovascular tests that might be ordered by your physician, which is going to provide a lot of information beneficial in providing care for you. So let me turn my questioning to Dr. Modi, who's really focused on stress testing. Now, people just don't order stress testing because they just want to have fun ordering these tests. These are serious studies that are being ordered because a physician is either concerned that the patient might be having symptoms that they think is cardiac based, or they want further evaluation. And it's good to know that UH has a number of systems in place, particularly while performing cardiac stress tests like nuclear scans or exercise echocardiography. So Dr. Modi, you practice in a very busy practice in Parma, where you see a lot of these patients. And in fact, just before you came into this webinar, you'd already seen a whole bunch of patients in your clinic. Can you, are you satisfied right now with the current response in hospitals, in the UH network, in Parma, for instance, where you practice, about necessary safeguards that are being put in place, so much so that exercise testing, which obviously we discussed in quite detail about aerosolization, can be mitigated with the appropriate masking, gowning, and shielding procedures in place?
Yeah, Dr. Rajagopalan, I think, first of all, I can't tell you that anything is going to be 100%, but I think the safety precautions that have been instituted at the UH hospitals and the ambulatory facilities with screening patients, even before they come here, we call everybody the night before to assess for any symptoms and for guidance. But when they come here, the temperatures that are obtained in the lobby before they're actually allowed to come up to the office, the minimalization of people that come with them, and then the actual safety protocols here in the stress lab, I do feel it's a very safe environment. The masking, I think, has decreased the exposure a substantial amount because of the potential of aerosolization with exercise. Having the staff protected with N95 masks and face shields has obviously gone a long way to help enforce the protection for our staff. While we look at the potential risk, and again, I can never say that we mitigate that risk 100%, but I think we've done an incredible job of reducing it. We have to look at the opposite. The risk of undiagnosed cardiovascular disease is substantial. We're not talking about disease that can often wait for a few weeks or a few months until an appropriate diagnosis is established. The risk is life-threatening. And so while there is always going to be some unintended risk involved with coming into an institution, that risk is fairly minimal. What I try to, just like Dr. Hoyt was recommending and discussing, is the risk-benefit analysis. We're all focused on COVID-19 right now, and I think it's important, but let's not neglect other causes of risk. And I often tell patients one of the riskier things that they're going to do on the day of their stress test or any procedure is simply drive their car to the hospital. The annual fatalities from car accidents are not insignificant, 50,000 to 100,000. So the risk of the test is justifiably low. The university has done an exceptional job of reducing that risk and making the environment as safe as possible. But we want to make sure our patients are getting the test that they need, because the risk without the test is far greater.
Thank you for emphasizing that very critical point. In fact, you know, when we went into this as when COVID was sort of, you know, becoming a reality, and sort of a surge was becoming very much of a scenario in Ohio, we went through this process of essential versus non-essential. And one of the issues with that, one way of looking at it, is most patients with cardiovascular conditions are life-threatening. And, you know, some of the procedures that are often ordered for these patients are often for that very concern. And this became quite obvious because, unfortunately, I think many of our patients postponed having some of these procedures done. And now we are seeing a surge, not in COVID, but in cardiovascular conditions and patients presenting with heart attacks and strokes, which could have been avoided. So thanks for that. Let me turn a few questions, and as the audience, I think I'd like them to turn in their questions as well. Tiffany, for some reason, I'm not seeing all of the questions. If you don't mind, after this question, if you wouldn't mind posing those questions yourself to the panelists, that would be great. So my question was directed to both Dr. Rashid and Dr. Gilkison, who are obviously experts in the field of cardiovascular MRI and CT. And you talked about, Dr. Rashid, in your presentation about the natural distancing in MRI and CT, where the procedure is often done in a different room and the technician is often sitting outside, which often provides, you know, obviously the advantage in some ways of preventing exposure. And CT, on the other hand, can also be helpful in diagnosing some of the COVID conditions, because COVID is a condition that affects the lungs, and often the CT can provide a window to cardiovascular as well as lung involvement. So my question to Dr. Gilkison is, has he seen a number of these cases where patients are being sent in for cardiovascular testing and coincidentally happen to have COVID in their lungs? What are your thoughts on that? Or what has your experience been most specifically?
Yes, Sanjay, that's a very important and interesting question, and certainly the finding for us. We've actually seen in many situations when patients have come in for their CT scan, either for, even ironically, for patients who come in with belly pain and abdominal pain. Now, with abdominal pain and a CT scan of the abdomen and pelvis, parts of the lungs are included on these scans, and we have actually diagnosed minimally or asymptomatic COVID infection on these CT scans. Same is true of patients who had came in for actually neck CTs or even brain CTs when they had trauma. If any part of the lungs were included, actually we saw in many situations, and this is borne out both by our experience, but also the experience nationally and internationally, that often we can pick up very characteristic findings on those portions of the lungs that are included that make us realize that this patient may have infection and asymptomatic infection. And yes, many of the studies have shown that, that really CT scan, if the images are included, can be a very sensitive and pretty specific evaluation for possible COVID infection in these patients. Yeah.
Thank you. So there's sort of an unintended benefit of having some of these procedures ordered by your physician, where sometimes, unfortunately, we have to pick up a diagnosis of COVID, but that can often help because preemptive intervention and observation can be very helpful. All right,
Yeah,
so I'm not going to turn my attention on the question. This is going to be a rapid fire. We have another 5 minutes or so. We're going to go about the hour a little bit in deference to all the questions that we're getting. So I'm going to turn each of these questions in a rapid fire manner. So the first question is related to echo precautions, and one of the attendees commends UH in the arrangements being very impressive, but as a patient, how will I feel safe during the test? I don't have access to N95 or face shields. I don't know who around me has been exposed to the virus. Please suggest how a patient can proceed with echo with confidence that patient will be safe. Dr. Hoyt, quick, rapid fire.
Yes, quickly, yes, you will be safe. I think for all the reasons that we discussed earlier.
Yes, thank you. Another viewer and attendee asked, how long roughly is the calcium scoring test good for? I had one 4 years ago and it was 16. Have you seen these numbers go up in a short period of time? Or should I be good for many years concerned? I'll take that and basically say that if your clinical condition has changed, for instance, if your parameters, your cholesterol is not under control, you continue to smoke, your diabetes is getting worse or is not being controlled, it might be a good opportunity to make sure that your score is not progressed. As an aortic valve replacement patient, should I keep my June appointment with my cardiologist in person at Ahuja? Dr. Hoyt.
I'm sorry, I thought you were going the calcium score way here.
That's okay. So the question is, a patient with aortic valve replacement, should he keep his appointment with my cardiologist in person at Ahuja?
Well, I actually prefer in-person visits as opposed to virtual, and I think that the virtual, examination, it has an important role, an important place. But if you are going to be, I think, undergoing something like this, I would suggest keeping the appointment, yes.
Thank you. And especially with an aortic valve, I think it'll be best served by seeing your physician in person.
Right. I mean, there's only so much you can learn from the virtual exam.
Thank you. Dr. Gilkison, if a person has a cardiac CT in early February and had a score above 600, would any procedure be indicated? And if so, would that likely be a less invasive procedure?
There are different, I would actually probably have to defer, actually may defer to Sanjay as a PCP about what would you do. I have some ideas, but what would you do if one of your patients had a calcium score of 600?
Yeah, I think I would say that, and again, Dr. Gilkison and I participate in many, many conversations about these types of CT scores. And both of us would say that if your score is above 600, that indicates a very high risk for future events. So I would, first of all, confer with your cardiologist. It could be by virtue of a virtual visit. You can call the number on the screen here, schedule a virtual visit if you sort of just want to discuss what the options are. And there are lots of things that we could do with treating you with medications. No procedure might be indicated for that. It might just require some intensification of treatments that you might already be on. So I look forward to you calling the number and scheduling an appointment. How much of a negative impact, specifically lessened ability, would you anticipate with a patient needing to wear a mask during a treadmill stress test? Great question. Dr. Modi?
Yeah, that is a great question. There's no doubt trying to exercise with a mask on your face is definitely not as advantageous as exercising without the mask. It doesn't have as much of an impact as you might think, and we've experienced this over the last couple of weeks where our patients who are exercising are still performing at fairly good levels. We've noticed that some of the homemade masks, some of the cloth masks are more restrictive. And so when we've replaced them with one of our surgical or paper masks, most of the patients have had an easier time breathing through that. But there's no doubt, it does limit the exercise capacity to some degree.
Great. And final two questions, and this is directed to Dr. Rashid. What, if any, imaging is done for AFib?
Yeah, it's a great question. I mean, I think going on from what Dr. Hoyt had said earlier, I think if a patient has a new diagnosis of AFib, AFib is downstream of many medical conditions, but your standard echocardiogram is probably going to be your first port of call and kind of an essential part of us to assess the basic structure of the heart, to assess the structure of the valves. Importantly, it's very important for us to distinguish whether the AF is downstream from a valvular issue, because it has implications for the way we treat it. And we can also look at structurally, basically what is the size of the heart, basically chambers, what is the function of the heart chambers, what is the size of the atria. So that's where the abnormal circuits from the atrial fibrillation often originate. So we can get a lot of that basic information, which has treatment implications as well, based on your standard echocardiogram. So that would be your first imaging port of call.
Great. There are two questions which seem like consults, but I'm happy to give you some broad guidance. Unfortunately, I can't give you any specific information. One is pertaining to an asymptomatic individual with calcium scores of 196. Recently, does this need any treatment or intervention? And the viewer says the blood pressure is normal, diabetes is under control, looks like the person's very fit, never a smoker, no symptoms. But however, father died at the age of 55. Now that's a trigger. You have a positive family history, but you are 74 years of age. Should anything be done? Well, what I would say to you is there might not be anything additional that we might need to do except look at your medications. But in order to do that well, I would say we could do this virtually. So if you call the number and make an appointment, we'd be happy to go through your condition and provide you recommendations. And this might not even warrant you coming in to the hospital at the current time. The second question pertains to stress tests. I guess this individual had several stress tests for preventive measures. Again, develops palpitations or skipped heartbeats 2 to 3 times a year during sleep. No chest pain. What type of test might be recommended? This obviously is occurring quite infrequently, but nonetheless, there are lots of conditions that can give you abnormal heart rhythm. And that's obviously something that you might want to evaluate if that necessitates some additional testing, such as an event monitor, just to record your heart rate, to find out a little bit more. We can take care of that. But again, this might be worthwhile just getting a consultation, a virtual consultation. final question, in pediatric cardiology, how many cases have been coming through and how similar are the symptoms? Now, that's a very broad question. I can't specifically tell you, but we are seeing that a number of the cardiology pediatric patients who are undergoing testing for necessary conditions, many of them have congenital heart disease, and those tests need to be done. And where appropriate, these patients are getting scheduled evaluations in the UH environment. So with that, we've run out of time. Actually, we've exceeded the time allotted to us. And I'd really like to give a word of thanks to my superb panelists who helped through this. And again, as always, very thankful to our audience who participated in this. Please keep asking those questions. Please send any questions you have to Tiffany Hatcher. And obviously, if you have any questions that we should be addressing, please don't hesitate to contact us on the phone lines and schedule a virtual appointment or an in-person visit if indicated. Thank you once again. Have a wonderful afternoon and a great weekend. Thanks for joining. Bye-bye now.